So good morning, everyone. My name is Jamie Ahlers. I'm an infectious disease epidemiologist with the Division of Public Health. I'm here with my colleague, Dr. Doug Riley.
And I'm Dr. Doug Riley, and I am the state public health veterinarian.
And today we will be providing you guys with an MPox update. So on today's agenda, we will be providing you with some background information, clinical guidance, testing, vaccination, treatment efforts, Delaware case statistics, public health surveillance, and resources. So I just want to start off with a quick terminology update. As Dr. Hong said, the Delaware Division of Public Health and CDC are updating websites and materials to reflect the change from monkeypox to MPox. This change is aligned with the recent World Health Organization decision, and it's intended to reduce stigma and other issues associated with prior terminology. So now going into a clinical overview. So MPox belongs to the orthopox virus family, which we will talk about a little more in depth. Symptoms of MPox are similar to smallpox, but milder and less deadly. People with MPox get a rash that may be located on or near the genitals or anus and can be in other areas like the hands, feet, chest, face, or mouth. These cases may also experience flu-like symptoms such as fever, chills, swollen lymph nodes, muscle aches, etc. And it's important to complete a full clinical evaluation and not assume MPox. Symptoms of MPox typically begin within 3 weeks of exposure, and a rash will typically start 1 to 4 days following these flu-like symptoms. It's important to note that not all cases of MPox will experience these flu-like symptoms, and some individuals will experience flu-like symptoms following rash onset. So in this outbreak, most cases of MPox have been associated with close, personal, often skin-to-skin contact. Although less common in the current outbreak, MPox may also be spread by touching contaminated objects, fabrics, and surfaces that have been used by someone with MPox, as well as contact with respiratory secretions or through transplacental transmission. A person with MPox is considered contagious from symptom onset until the rash has healed and new skin has formed. This could take approximately 2 to 4 weeks. And it's important to note that some cases will experience scarring, so they might have a light, dark, or even indented spot where the lesion had been. That's perfectly normal. They're not considered infectious any longer.
Good morning. I'm going to make a disclaimer in the beginning. I may actually slip and say monkeypox because I've been brought up with monkeypox, and that's just how I know how it is. That's the common name for me. So forgive me if I use that term. For me, I think that the most important thing that we need to understand is how to understand the enemy. For me, understanding how the enemy works, invades, reacts, and responds is critical to control. In my past life, we called this techniques, tactics, and procedures, better known as TTPs. By understanding the enemy, you can better craft countermeasures and thwart the enemy prior to its gaining a strong foothold on the battleground. Make no mistake, we are in a battle against many different pathogens that are growing in prevalence and in strength as antimicrobial resistance, which we all know is a big problem currently, and we can no longer sit and wait. We need to be proactive, driven, and looking for the unexpected. Orthopox is in the genus Poxviridae in the subfamily Choroidopoxviridae. Vertebrates, including mammals and humans, as well as arthropods, serve as natural hosts. There are 12 species in this genus. Diseases associated with this genus include smallpox, cowpox, horsepox, camelpox, and monkeypox. The most widely known member of this genus is variola virus, which causes smallpox. It was eradicated globally in 1977 through the use of vaccine virus as a vaccine. The most recently described species is the Alaska pox, first isolated in 2015. The basis for vaccine began in 1796, when the English doctor Edward Jenner noticed that milkmaids who had gotten cowpox were protected from smallpox. Jenner also knew about variolation and guessed that exposure to cowpox could be used to protect against smallpox. To test his therapy, Dr. Jenner took material from the cowpox sore on a milkmaid, Sarah Nell's hand, and inoculated into the arm of James Phillips, the 9-year-old son of Jenner's gardener. Months later, Jenner exposed Phipps several times to variola virus, but Phipps never developed smallpox. More experiments followed, and in 1801, Jenner published his treatise on origin of vaccine inoculation. In his work, he summarized his discoveries and expressed hope that the annihilation of the smallpox, the most dreadful scourge of human species, must be the final result of his practice. So again, going back to understanding the enemy, this is going to take us all back to virology and pathobiology and how we should look at disease, because as we all know, disease only has a limited response in any body system. So we're going to start with just a short, there's no testable material in here, don't get concerned. So viral replication is cytoplasmic. Entry into the host cell is achieved by attachment of the viral proteins to the host glucosaminoglycans. You all know it like I know it as GAGs, which mediate cellular endocytosis of the virus. Fusion of the viral envelope with the plasma membrane releases the viral core into the cytoplasm. Expression of early phase genes by viral RNA polymerase begins at 30 minutes after infection. The viral core is completely uncoated as early expression ends, releasing a viral genome into the cytoplasm. At this point, intermediate genes are expressed, triggering genomic DNA replication by the viral DNA polymerase. About 100 minutes post-infection, replication follows the DNA strand displacement model. Late genes are expressed from 140 minutes to 48 hours post-infection, producing all viral structures and proteins. Assembly of progeny virons begin in cytoplasmic viral factories, producing a spherical immature particle. This viral particle matures into brick-shaped intracellular mature virons, which can be released upon cell lysis, or can acquire a second membrane from the Golgi apparatus and bud as extracellular enveloped virons. In the latter case, the virons are transported to the plasma membrane via microtubules. So again, this is not something that's testable, but I'm sure that you all enjoyed that brief return back to medical school. So let's talk about distribution. This is where this is where it's very important that we understand, because some orthopox viruses, including the monkeypox, cowpox, and buffalo pox virus, have the ability to infect non-reservoir species. Others, however, such as the ectomelia and the camelpox virus, are highly host-specific. Vaccinia virus, maintained at vaccine institutes and research laboratories, has a very wide host range. Vaccine-derived vaccinia has been found replicating in the wild in Brazil, where it has caused infections in rodents, cattle, and even humans. Following the eradication of the variola virus, camelpox has become the most economically important orthopox virus infection, because many subsistence living nomadic communities depend heavily on the camel. So in endemic countries, only wild animals, rodents and primates, have been found to carry MPox. However, transmission of the MPox virus in prairie dogs has been described in the United States of America and in captive primates in Europe that were in contact with imported infected animals. Infection among domestic animals, such as dogs and cats, has never been reported. And we're going to caveat there, because that is until recently. So my question to the group, and something that we all need to ponder, is there a concern that the virus will become established in the United States? So here are a few commentaries that I found out in the recent literature. The introduction of the virus into domestic and wild animal populations is a major concern, as it may lead to the virus becoming endemic. What does that mean for us? Well, I guess that would mean that you'd be seeing monkeypox more often, kind of similar to chickenpox or any other pox virus, and you'd enter into the world of the veterinarian, where we deal with pox virus in cattle and pox virus in goats and sheep. The very recent report of a dog that became infected with monkeypox virus shows that human to domestic animal transmission is possible, but not that the virus will persist and spread in domestic or wild animals. We need to pursue aggressive efforts to control MPox now, which now have the potential, and which monkeypox now to have potential to prevent the development of endemic MPox. This is something that we and you will have to decide in the near future. Currently, about 75% of all human cases have occurred due to human transmission, and sporadic outbreaks continue and are a concern to human health. It was in 2003 that the first case appeared in the United States as an exposure to an ill prairie dog, which is thought to have been exposed to infected West African small mammals imported as exotic pets. Is there a possible larger threat? I'm going to go through a short case, and this will kind of drive a very important thought process for all of us. 12 days after symptoms onset, their male Italian Greyhound, aged 4 years, and with no previous medical disorders, presented with mucocutaneous lesions, including abdominal pustules and a thin anal ulceration. The dog tested positive for monkeypox virus by use of PCR protocols adapted from Lyon colleagues that involve scraping the skin lesion and swabbing the anus and oral cavity. Monkeypox virus DNA sequenced from the dog and patient 1 were compared on next generation sequencing. Both samples contained virus of the MPXV-1 clade lineage Bravo 1, which has been spreading in non-endemic countries since April 2022. Moreover, the virus that infected patient 1 and the virus that infected the dog showed 100% sequence homology on the 19.5 kilobase pairs sequenced. The men were co-sleeping with their dog. They had been careful, however, since the positive diagnosis to prevent their dog from coming into contact with other pets or humans from the onset of their symptoms, which occurred 13 days before the dog started to present with cutaneous manifestations. It is important, very important to note, while some of the orthopox viruses are zoonotic, animal to man, either directly or indirectly, some, like camel pox that we discussed earlier, is very species specific. Now we're going to take a step back in history so we understand what we're talking about when species specificity and the potential for eradicating a problem. So let's talk about smallpox. The answer to this question comes from the outcome of the vaccine program as to whether or not it is a zoonotic disease. And again, we're talking about smallpox. In 1977, the last naturally acquired infection was an Ali Mahmoud Malin in Murcia, Somalia. An additional case from a laboratory contracted disease was seen in Janet Parker, who died of the disease. It was in May of 1980 that the world was declared free of the virus by the World Health Assembly. This is still considered the most important achievement in international public health. But again, the question that I'm asking that does not fit for monkeypox, but does fit for smallpox, is smallpox a zoonotic disease? Again, the answer does come by the end of this short presentation on zoonoses. The question I'm going to pose to all of you, which you don't have to answer, is, was any other disease that we know of in written history ever been eradicated on a global scale? If you're a veterinarian and you're sitting out there, I'm willing to bet you probably know the answer to this question. Because the answer to the question is yes. On 14 October 2010, the United Nations Food and Agricultural Organization, better known as the FAO, announced that field activities in a decade-long worldwide campaign to eradicate the disease were paving the way for formal eradication in June 2011 and global eradication of the disease rinderpest. So the question then is, what does rinderpest, which is not a pox virus, have in common with smallpox, which is a orthopox virus? So if you think about it, the things that are in common with the two of them are they are both highly species specific. So to answer the question of the zoonotic component of smallpox, smallpox is not a zoonosis. It is a species-specific, human-specific disease, much the same as rinderpest. Why is that important to this entire discussion of monkeypox? If you are sitting out there and you know the answer, that's most excellent, because I'm about to reveal the answer. The importance when it comes to monkeypox is that we and you need to work together in order to find a way to avoid monkeypox from entering into another species. Because once a virus or a bacteria or a pathogen, let's use the word pathogen, enters into the wild, it becomes infinitely more complicated to eradicate the disease, because you will always have a foothold in another animal kingdom. Much is the case for rabies, which was mentioned earlier by Dr. Hong. Rabies is the quintessential zoonotic disease and one of a very large concern, but to eradicate the disease is almost impossible simply because it resides outside of just the human species. So this brings us to One Health. This is actually a very good segue into One Health, because I'm just going to mention this briefly because I think that we all need to understand what One Health is. One Health is an interaction, as you can see, according to the slide, is coordinating, communicating, and collaborating. But in what realm are we talking? We're talking about doctors talking to doctors. We're talking about doctors talking to public health. We're talking about doctors talking to environmentalists and veterinarians. The answer to all those questions is yes, because One Health can be summed up quite simply. One Health is the interaction or the synergy of action between human health, animal health, and environmental health. I put the fourth silo on there simply because without a policy to drive the process, the process will not drive forward. If we don't have policy, we don't have someone saying that you will do this, then human nature, just my human nature, your human nature, I'm assuming, would drive that we would continue to be siloed in how we function. Because if we were to truly enact a One Health program, our silos, which you see here, are disconnected and not communicating, would look more like these silos. These silos share information via an elevator. It moves information across the top and dumps it into each of the other silos. So we can all gain information collaboratively because we all have enough information to help mitigate a problem. And the premise of One Health is to create a solution to a problem that reduces impact on the overall health of all three of the components of One Health. And what does that mean? That means that we have to talk. Is there a means for us to do that? There is. The state has a state partnership for One Health that meets usually once a month. And we try to come up with solutions to problems before they become major problems. We also have a regional consortium with the Eastern Seaboard that works the same way. And the outcomes of those meetings will be available if you are interested in those. And if you wish to become a part of that, you just need to ask, and we will add you to our list of members. Because what we don't want the slide that you had a sneak preview of, we don't want our silos to become dilapidated, broken down, and not communicating. Because that would mean that we're not sharing information and we are reverting back to the way we were a decade ago, because right now we are communicating. Because you need to remember that the origins of One Health or One Medicine has been around a very long time. The concept goes back as far as 400 BC in Hippocrates on air, waters, and places. And in most more recent times, Dr. Calvin Schwab, the founding faculty member of UC Davis's School of Medicine, as well as an epidemiology professor at the School of Veterinary Medicine, coined the term One Medicine in his book, Veterinary Medicine and Human Health in 1964. Dr. Schwab was a pioneer in bridging the veterinarian and human health professions and held joint appointments in both schools at UC Davis. In the ensuing years, the approach took root and gained prominence. Recognizing its values, the CDC established its One Health office in 2009, advancing the concept globally. So again, monkeypox is now a One Health problem. It's in the human world, it's in my world. We need to be able to share that information, best practices, and therapies. I look forward to the challenge, and I look forward to advancing the One Health and the bridges that collaborate us. I will see you all on the battlefield.
Thank you, Dr. Riley. So now we're going to move on to some clinical guidance. What to do if you suspect a patient has MPox. So we would recommend collecting a specimen and sending it out for testing. Healthcare providers should also be aware of the risk factors for severe manifestations of MPox and should conduct HIV and other STI testing for people with confirmed or suspected MPox. It's important to protect your patient, yourself, and others by having the patient wear a mask and placing them in a single-person room. Follow CDC's infection prevention and control guidelines for healthcare facilities, which includes using appropriate PPE around the patient. So for PPE, we would recommend standard precautions with gloves, gowns, eye protection, and a well-fitted mask, N95 or higher for patient care. And we would encourage you to use PPE when handling dirty laundry and cleaning and disinfecting. When cleaning and disinfecting, we would encourage hand washing after touching lesions or clothing, linens, or surfaces that may have had contact with infected lesions using soap and water or hand sanitizer with at least 60% alcohol. Avoid activities that can spread dried material from lesions, which includes fanning, dry dusting, vacuuming, and shaking soiled laundry. Use an EPA-registered disinfectant and launder using regular detergent and warm water. We would also encourage you to share resources with your patient. There's a ton of useful information on the CDC website under their healthcare professionals tab. These resources include how to manage symptoms and rash relief, how to identify close contacts and tips on what to say, if treatment might be right for them, as well as how to prevent spreading MPox to others. So now moving on to testing, vaccination, and antivirals. The latest CDC specimen collection guidelines can be found on the CDC website. At this time, we recommend collecting at least 2 dry swabs from the same lesion, no deroofing, and no transport media. As you can see here, the CDC recently published an MMWR. This report describes the first occupationally acquired MPox infection in a U.S. healthcare worker during this outbreak. The CDC advises against unroofing and opening MPox lesions with sharp instruments because of the risk for injuries. Vigorous swabbing of the outer surface of a lesion is adequate to collect enough viral material for testing and will also minimize the potential for needle sticks. The Delaware Public Health Lab is also conducting antiviral resistance mutations testing for cases that have developed new lesions during or post-treatment with tecovirimat. We're also in the beginning stages of whole genome sequencing, which I will discuss a little more in depth shortly. So for cases that have clinical suspicion of MPox with at least one risk factor, we would consider them high priority and have their specimens sent to our Delaware Public Health Laboratory for quick turnaround. If the case presents with clinical suspicion without any risk factors, they should be considered low priority and their specimen should be sent to the commercial laboratory. Examples of individuals at increased risk of MPox infection during this ongoing 2022 outbreak includes those who report having contact with a person or people with a similar appearing rash or contact with an individual with MPox, as well as those with close or intimate in-person contact with individuals in a social network that's experiencing MPox activity. At this time, this includes men who have sex with men who meet their partners through an online website, digital app, or social event. So Delaware is treating eligible persons with MPox using tecovirimat, also known as TPox. At this time, eligible persons include individuals with severe clinical manifestations, involvement of anatomical sites that might result in serious long-term consequences, individuals at high risk of severe disease, which includes those with immunocompromising conditions, pediatric populations, pregnant women, etc. EMSPS orders the allocated amount of TPox through the Strategic National Stockpile, and small stockpiles of TPox are kept at the Delaware Public Health Warehouse and hospitals. At this time, there have been 11 courses administered here in Delaware, and six courses are remaining at our Delaware Public Health Warehouse. We are also using Jinios to vaccinate individuals against MPox. At this time, eligible persons include persons with known or presumed exposure to someone with MPox within the last 2 weeks, certain individuals who have sex with men and have had multiple sex partners within the last 2 weeks, those living with HIV or receiving HIV PrEP, immunocompromised persons, those treated for an STI within the last 6 months, those engaging in high-risk activity, which includes sexual practices that increase exposure to MPox, and staff at establishments where sexual activity occurs. To be screened for eligibility, we would encourage you to reach out to our MPox hotline seen below. It's important to understand that while there may be many individuals in Delaware who wish to protect themselves from MPox, not everyone in the population needs an MPox vaccine. Things that people can do to protect themselves, regardless of their ability to access the vaccine, include limiting direct contact with anyone with a concerning rash, limiting the number of intimate contacts, talking openly with intimate contacts about recent behaviors, and not sharing bedding, towels, and eating or drinking utensils with individuals experiencing symptoms of MPox. As of December 9th, 1,784 individuals received their first dose of Jinios. 1,421 received their second dose, with a total of 3,205 doses administered here in Delaware. To order Jinios, you can fill out a shock resource request form found on the de.gov/MPox website, but please remember to report through Delvax within 24 hours of administration. Moving on to case statistics. As of Friday, December 9th, 29,711 cases have been reported in the United States in all states, with 20 deaths in total. As you can see here, Delaware is within the 11 to 50 range. We currently have 43 cases. So this is our current epi curve. Our first case was identified the week of July 3rd. And we experienced a peak the week of August 28th with 7 cases reported in a single week. Since then, we've seen a decrease in our cases, with our most recent cases being reported the week of November 6th. Moving on to some demographic information for our 43 cases. The median age is 33 years old, with cases ranging from 19 to 58 years old. 98% of our cases are male at birth, 60% are Black or African American, 74% non-Hispanic or Latino, and 60% describe their sexual orientation as homosexual. At this time, there have been no deaths and no hospitalizations, and we've successfully interviewed 34 of our 43 cases. If you look at the map on the right-hand side, you'll see the geographic distribution of cases by zip code here in Delaware. 67% of our cases reside in Newcastle County, followed by 21% in Sussex and 12% in Kent. So on September 29th, the CDC released a health advisory in regards to severe manifestations of MPox amongst people who are immunocompromised due to HIV or other conditions. So the CDC recommends testing all sexually active adults and adolescents for HIV and other STIs, as well as assessing for other immunocompromising conditions upon initial presentation of signs and symptoms consistent with MPox. This HAN also states that 38% of people diagnosed with MPox in the US were co-infected with HIV, which, as you can see on the right-hand side, is consistent with what we're seeing here in Delaware, with 37% of our cases reporting a positive HIV diagnosis. Since most reported cases of MPox with severe manifestations have been amongst people living with untreated HIV, we would encourage you to conduct HIV testing to identify undiagnosed and untreated cases. So if you look at the diagram here, you'll see MPox symptoms during the course of illness for our Delaware cases. 100% of our cases reported experiencing rash, with more than half experiencing enlarged lymph nodes, and a large majority also experiencing fever, chills, and weakness. 58% of our cases reported other symptoms not identified here. Of these symptoms, many reported sore throat, fatigue, shortness of breath, diarrhea, and more. Some of these symptoms may be associated with co-infections due to other diseases such as COVID, pneumonia, and others. The diagram on the left displays location of rash onset. Most of our cases experienced rash beginning in their genital region as well as their face. Many of these rashes did spread to other parts of the body, as you can see with the diagram on the right, which displays the location of rash during illness. More than half of our cases experienced rash on their arms and face, as well as a large percentage experiencing spread to hands, legs, trunk, etc. Moving on to public health surveillance. MPox is a reportable disease here in Delaware, so we do receive electronic lab reports through our surveillance system known as FEARS, as well as provider call-ins and self-reported cases. We do pursue investigation based on exposure reports, as well as using syndromic surveillance through our system known as Essence, which analyzes chief complaints / ICD-10 codes and helps us identify unreported cases. The case definitions seen here are the case definitions for MPox that both the CDC and Delaware Public Health are using. A suspect case is an individual with a new characteristic rash, or someone who meets one of the epidemiologic criteria and has high clinical suspicion for MPox. A probable case is someone that demonstrates the presence of orthopox virus DNA, and a confirmed case demonstrates the presence of MPox virus DNA. So at this time, the Delaware Public Health Lab, as well as a majority of the commercial labs, are testing for orthopox virus. Early on in the outbreak, we were sending specimens to the CDC for confirmation of MPox virus DNA. However, since MPox is the only orthopox virus that we are seeing circulate here in the United States, we feel very comfortable treating these orthopox positive individuals as MPox positive. Please remember to report any suspected, probable, and confirmed cases to the Division of Public Health. So when interviewing cases, we gather demographic information, clinical information, and both pre-illness exposures as well as post-illness exposures for contact tracing. We recommend isolating in a room with a door and a dedicated bathroom if the individual resides with roommates. And we also encourage wearing a well-fitted mask over the nose and mouth and wearing long pants and sleeves to cover skin lesions if the individual must leave isolation. We would also encourage the individual to take antivirals if they are eligible and recommend isolation until scabs have fallen off and new skin has formed. When contact tracing, we conduct a risk assessment for any identified close contacts. With this, we're able to classify them as high, intermediate, low, or no risk. We provide these individuals with education and do not advise them to quarantine if they are asymptomatic. We do advise against blood, cell, tissue, breast milk, semen, or organ donations. We encourage some intermediate and all high-risk cases to receive post-exposure prophylaxis and enroll all high, intermediate, and low-risk individuals into daily symptom monitoring. For our intermediate and high-risk individuals, we enrolled them into a system known as TIM, which is Text Illness Monitoring from the CDC, which sends them a daily text screening them for any symptoms of MPox. And for our low-risk individuals, we advise them to self-monitor for 21 days from their most recent contact with an MPox case. If these individuals were to present with any symptoms of MPox during their monitoring period, we would ask that they report it to us so that we could assist with testing if necessary. Moving on to genomic epidemiology. So far, we have successfully uploaded sequencing data of MPox virus to NCBI, which is the National Center for Biotechnology Information, for further use in research and surveillance. We were able to determine the clade of samples, which is critical in determining the threat level. So clade 1 is high concern, clade 2 is low concern, and thankfully to this date, all of our cases have been classified as low concern. We're also using the phylogenetic trees for cluster detection. Moving on to some Delaware resources. We encourage you to check out our website at de.gov/MPox, where we have public and medical provider information, including flyers and other resources. We would also encourage you to check out the CDC for useful resources on things such as clinical considerations for MPox in children and adolescents, isolation and prevention practices for people with MPox, and the latest statistics. We also have an MPox hotline that's available during office hours, which is 8 a.m. to 4:30 p.m. Monday through Friday. We also have flyers in both English and Spanish, as well as press releases, media interviews, and social media posts. Does anyone have any questions?